This conference will now be recorded.
Good morning. Thank you for joining us to hear from our Lurie Head and Neck Surgery team member, Dr. Doug Johnston. Dr. Johnston is one of the nation's leading experts in transoral robotic surgery, and he's going to address branchial cleft anomalies. Dr. Johnston, take it away.
I think Monica is on. Monica Huron, our physician assistant. I think she has a few words to say first, and then we'll start with the presentation.
Yeah, thanks, Doug. Just wanted to introduce myself to everyone. Thanks for joining us this morning. Like Dr. Johnston said, my name is Monica. I'm a physician assistant that supports the entire head and neck program. So I work with all of the surgeons that you'll see today, Dr. Johnston, Dr. Esteder, and Dr. Matalozzo. I just wanted to point out that you're always free to contact me. I work with them in all capacities in the clinic, in the hospital, and in the operating room. So if you need any help with appointments or organizing imaging or lab tests or specialist appointments along with ours, such as endocrine or oncology or infectious disease, I'm happy to help with that. You'll see my contact information in this presentation, but we also have an email address. It's just headandneck@luriechildrens.org. You can use that email address. You can give that email address out to parents, and we're happy to cut through a little bit of the red tape and get right to contacting them and whatever questions that they have. So I can take questions later and happy to send them to Doug as well, but Doug, take it away. Doug, you're muted.
I think you learn these things after time, but anyway, I'm Doug Johnston. Thank you, Monica, for the introduction. Thank you, Paula and Chad, for being our physician liaisons and helping us to connect with pediatricians in the community. We want you to know that we're available. Please reach out to us if we can be of help with your patients, whether it be a head and neck related issue or anything general as well, because we also do a lot of general pediatric otolaryngology. So today we're going to discuss, and I'm going to share my screen with you here, branchial cleft anomalies. Okay, good. So branchial cleft anomalies are a common head and neck mass in children that I'd like to introduce you to. I'm sure you've heard of it before, but we'll do a brief introduction today into these. We don't have a ton of time, and we can always go into more depth if anyone has specific questions. So basically, my goal is to teach you about branchial cleft anomalies. There are types 1 through 4. Types 3 and 4 are generally linked together, meaning that they're hard to distinguish clinically and radiographically. So we'll lump those together. So we have basically types 1, 2, and then the 3, 4 combination. So how do each of these present? Where do they present anatomically? What type of symptoms are we going to see, and how we distinguish these things? And then how are we going to treat them? So first, unfortunately, we have to talk about embryology, which is not one of my favorite things to do. It was one of my least favorite classes in medical school, but we do have to review it for the purpose that it is relatable in this instance. The different types of branchial anomalies have embryologic developmental links, if you will, to the anatomic presentation that they have, and so therefore it is related. So the term branchia actually refers to a Latin word for gills, and this is relatable because the developing amphibian has gill slits that are similar to the developing embryo, and so that's why the term branchia has been used for branchial cleft anomalies. So sorry, I'm going to move something here. Okay, great. Each branchial system has an arch, a cleft, and a pouch, okay? And the arch is of mesodermal origin. And each branchial arch develops into a corresponding nerve, blood vessel, and muscle group, and also a skeletal component in some instances. The clefts are on the ectodermal side of things. Think of it on the skin side or the outside, whereas the pouches are of endodermal origin. Think of those being on the inside. Typically, the clefts and the pouches are going to obliterate with time as the embryo develops. But in the case of incomplete obliteration, there is then a branchial cleft anomaly. Now, depending on the extent of that obliteration, you can have either a cyst, meaning an isolated cystic structure that is oftentimes fluid-filled, or you can have a sinus, which means that there is a connection between either the skin or the pharynx, for example, and a cyst, or a fistula, which means that there's a connection between the external world and the internal world. Okay, let's go on to the basic presentation of branchial anomalies is going to happen between ages of 0 and 5 in most cases. And this is because they are going to get infected or have drainage. Something is going to alert the clinician that these are present, especially fistulas, because there's an external skin opening. And so fistulas usually present before cysts and sinuses. The second branchial cleft anomalies are the most common variety. We will discuss those. There's not usually a gender or laterality predilection, but there is on a few occasions. For example, a complete second branchial cleft fistula, one that presents in the skin and goes into the pharynx. Those are more common on the right side, whereas the third arch anomalies and fourth arch anomalies are more common on the left side. Who's excited? I can feel the excitement. I can't see the excitement, but I can feel the excitement. All right, let's talk about, this is the first point of discussion. It's not actually an arch derivative, but I want to mention branchial cleft pits because they do develop from the branchial system, but they are developmentally from what's called the Hillocks of His. Now, the Hillocks of His, you can see on this top picture that there are numbers 1 through 6. So the first hillock of His, for example, develops into the tragus. The second hillock of His develops into the root of the helix, and the third, the ascending helix, etc. When there's an abnormality in these, you can see a preauricular pit, which is a very common thing to see. And on most occasions, preauricular pits can be observed because most of them do not get infected. But you can see in this bottom picture, this right ear, and you see a preauricular pit, and you can see that there is some skin necrosis and scabbing in front of the ear. So this is an example where there has been an infection. Once they get infected, they usually continue to get infected. And at that point, surgical excision is recommended because the longer you wait and the more they get infected, the more difficult the excision can be. Because not only is there a skin tract, skin line tract, they could be blind ending near the cartilage of the ear, but it could also have a cystic component deep to the surface, as indicated by skin necrosis or an abscess that develops in the front of the ear. So most of these need to be handled surgically if they've been infected. Another example of a hillock of His abnormality would be a preauricular skin tag, and these are usually just cosmetic, and oftentimes families want those removed. To get on to the true first branchial cleft anomalies, I'll demonstrate here in this slide that there are 2 different types, and this is based on what we call the work classification. So there's a work type 1 and a work type 2. The work type 1 classification is ectodermal in origin, and it usually represents a membranous duplication of the external ear canal, and it's usually a cyst. So if you look at the diagram in the center of the slide, we see a black circle here. This black circle represents a cyst, and this is work type 1, and it can be located anywhere around the external auditory canal. It doesn't have to be posteriorly situated. Now, work type 1, we can see a picture of one of these on the top slide where there is a child. You can see the left ear, and just behind the left ear, we can see a skin thinning and erythema. That is the area of a work type 1. Now, this child actually has work type 2 branchial cleft anomaly as well, which we can see in the submandibular space here. So work type 2 is different in that it represents both ectodermal and mesodermal origin. Now, work type 2 can have a relationship with the facial nerve. Work type 1, on the other hand, usually is superficial to the parotid gland, so it doesn't have a relationship with the facial nerve. But work type 2 can exist within the parotid gland. If you look at the center diagram, you see the orange linear structure here. That represents a fistula. A lot of times, work type 2 will have a fistula near the angle of the mandible, and that tract can travel through the parotid gland and have a variable relationship to the facial nerve, because it turns out that embryologically, as the parotid gland is developing, the first branchial cleft system is obliterating. So it can have a relationship either above or superficial to the facial nerve or deep to the facial nerve. So oftentimes a parotidectomy approach has to be done to remove these surgically in order to identify the facial nerve. So let's look at this bottom surgical photo of this patient who had this skin thinning and submandibular skin tract that was followed surgically superiorly and identified here. If you can see on the cursor that there is a ruptured cyst. And because this work type 2 can both have ectodermal and mesodermal components, we can also see that there is a cartilaginous component. You could also have skin adnexs or hair, but there's a cartilaginous component. And these lesions, work type 2, they usually extend towards the ear canal, the junction of the bony and the membranous ear canal. Okay, we can see that this is the sternocleidomastoid muscle posteriorly here. We see the posterior belly of the digastric muscle. You can see that the parotid gland was exposed. The facial nerve was identified in order to keep it safe and protected in identifying the tract of this type 2, work type 2 anomaly. Okay, here's another look at a work type 1 lesion. It is existing posteriorly in this instance as a cystic structure. A work type 2 lesion where you can see a skin opening, likely has a fistula connection to the angle of the mandible. One other feature of these work type 2 lesions is that they can actually open in this fistula way into the external auditory canal, and therefore can have recurrent otorrhea. They can actually open into the middle ear cleft and present with recurrent middle ear fluid. So in the first branchial anomalies, you can sometimes actually have some other ear manifestations, such as drainage or recurrent infection, and that can help distinguish lesions clinically. If you look at the imaging, that can also give us an idea of what's happening. This depicts here an axial picture of an MRI. We can see on the left side of the patient, there is a cystic dilation behind the ear, and this represents the branchial cleft anomaly. We see also the parotid gland here. And we can see that the tract, the cyst here and the tract leads to the parotid gland. So this tells us that it is a first branchial cleft anomaly. So the imaging is quite helpful. If we want to look at some surgical pictures, the lesion here in this patient is located postauricularly. It's a little bit hard to see on this image, but a parotidectomy incision is planned out. We can see there are facial nerve monitors here to monitor the function of this critical structure. We can see the dots here represent the anterior border of the sternocleidomastoid muscle, and this right angle drawing here represents the angle of the mandible. So after the skin flaps are elevated, we find a cyst in the region just posterior and inferior to the external ear. We can see that the great auricular nerve was dissected out to protect sensation to the ear. And further on in the dissection, as I mentioned earlier, this lesion has a variable relationship to the parotid gland and the facial nerve, so a parotidectomy approach has to be done. This included identifying the facial nerve, which is shown here by this forceps pointing towards it. And we can see the common facial vein there as well, a close-up of the facial nerve. And if you look at the tract of this lesion, after it is freed up from this region here, the tract extends, as I mentioned before, to the junction of the bony and the cartilaginous ear canal. That's not fully depicted there, but you'll have to take my word for it. Okay, That is first branchial anomalies. Why don't we jump on to the next topic? If anyone has questions, please interrupt me during the presentation here. This is not a formal thing. I'd like to make sure we all come away with something from this. All right, second branchial cleft anomalies are the most common, representing 70 to 90% of lesions that are branchial in origin. The cysts of the branchial cleft, second branchial cleft, often arise deep to the sternocleidomastoid muscle, and they can have a sinus opening or a fistula opening anywhere along the anterior border of the sternocleidomastoid muscle, even down to the clavicle. So if you have a patient who has a skin pit along the neck, along the anterior border of the sternocleidomastoid, it likely represents a second branchial cleft anomaly. Now, embryologically, it's such an interesting course that these can have. So because of the derivatives of the first arch and the second arch, we know that the tract, if you have an external skin opening and it truly is a fistula, this will travel deep and superior. It'll go in between the internal and external carotid branches. It'll travel superficial to the glossopharyngeal and the hypoglossal nerves, and then it will pierce the pharyngeal constrictor muscles in a very interesting way. And to finish it off, the second branchial pouches develop into the tonsillar fossa and the tonsillar crypts. So you can have even an opening of this fistula tract in the tonsils. So to take a look at some surgical photos of patients like this. So this patient presented to me with a small pit along the anterior border of the sternocleidomastoid muscle. There was some recurrent drainage from this region, but never got infected. We knew that we had to plan for at least an excision of the opening at the pit. This was injected preoperatively with methylene blue by our team so that we could follow underneath the skin where this tract was going. We then planned for what we call stair-step incision. If this proved to travel superiorly and was a true fistula, then we need to have extra room to work and follow this tract. So we planned for a second incision if needed, and sure enough, we did need it. The tract was dissected free and tracked superiorly. This shows us ligating the tract at the area of the pharyngeal constrictor muscles. Another example of a recurrent, a 2-year-old with recurrent submandibular swelling that had spontaneous drainage and required actually 2 incision and drainage procedures. She had a skin pit opening, and once we were able to get this calmed down, we did a surgical excision, including the skin pit opening, and tracked this superiorly. Now, there's some good drawings here. I mentioned where they travel theoretically, embryologically, and you can see this intraoperatively. If you have a cyst with perhaps an opening in the skin along the sternocleidomastoid, you follow that tract. It's going to go between the carotid branches, superficial to the 12th and the 9th cranial nerve, and pierce the pharyngeal constrictor muscles. Similar drawing is here. And surgically, another picture, this huge cyst traveling between the internal and external carotid branches, we can see here. So it's very interesting. Think of this in patients who present with a cystic neck mass deep to the sternocleidomastoid muscle. Preoperative imaging is often helpful. I don't want to go into too many of the details, but just to show you that we have this right-sided submandibular cyst anterior, located just deep to the anterior border of the sternocleidomastoid muscle. And if you follow it superiorly, you can see that it's going towards the pharynx. Here's the jugular vein here and the internal carotid artery. And on the larger blown up picture, we see that this tract continues and it's going towards that junction of the internal and external carotid arteries. So preoperatively on the MRI, we're getting an idea of what we might deal with intraoperatively. And there are some times that we use the imaging to help us, and other times that we don't have that luxury in that the imaging is not revealing. I mentioned also that one of the ways to distinguish between first and second branchial anomalies, if they do have submandibular swelling, is look for ear canal signs. Remember, recurrent otorrhea or middle ear fluid or ear canal erythema can indicate that it's a first branchial anomaly. And then sometimes we just figure it out in the operating room. We know it has to be removed. We follow it. We closely monitor nerves that are needed to be monitored, and we just look at the lesion and take what it gives to us. All right, I hope this hasn't been too painful so far because we have a little bit more to do. We're going to next talk about this combined entity of third and fourth branchial cleft anomalies. I lump them together because, as I said before, they're clinically and radiographically difficult to distinguish. They can occur in a similar region to second branchial cleft anomalies in that it can be deep to the sternocleidomastoid muscle. But what is distinguishing in these lesions is that there's a tract to the piriform sinus. Now, the piriform sinus is right near the opening of the esophagus, sort of lateral to the larynx, and I'll show you a picture of that. And there's an opening in this almost gutter, if you will, that leads into the cervical esophagus. So the hallmark feature of this, when you're trying to make a diagnosis of a third or fourth branchial cleft anomaly, it's usually going to be in a child who has a history of recurrent thyroiditis or recurrent thyroid abscess, because the cystic component of these and the tract of these goes towards the thyroid gland. So it can result in significant inflammation of the thyroid, even elevating thyroid enzymes, or significant inflammation in the neck. So here's a patient who has an MRI with contrast that's showing significant uptake in the neck, because this is during the time of an acute infection. We see even that the laryngeal structures here are being deviated to the other side, and because of the diffuse acute inflammation that even extends to the skin surface. We see also that within the thyroid gland, which is right here around the trachea or the airway, we see that there is some cystic component to this branchial anomaly. Here's a diagram that depicts a cystic component within the thyroid gland, and then it tracks superiorly. Theoretically, it pierces the thyroid membrane on its way to the piriform sinus. Now, these lesions are going to get infected more often than second branchial cleft fistulas, ones that connect with the pharynx more superiorly in the tonsil, because inferiorly by the piriform sinus is a more dependent position. And so oropharyngeal and oral cavity bacteria and foodstuffs can inflame the piriform sinus tract and causes more incidence of infection. So just to give you some anatomical awareness of where the piriform sinus is. So here's the larynx here, right? And lateral to the larynx is going to be the piriform sinus. You can almost get the sense there's a gutter here, and this would drain into the cervical esophagus. But in this patient, who we had a suspicion for a branchial cleft anomaly, we took them to the operating room to identify if there was indeed a tract. And here we see a mucosal lined tract within the piriform sinus, confirming our diagnosis. There are other ways to make this diagnosis, but none are as accurate as looking for that piriform sinus opening. There's 50% sensitivity to getting a barium swallow test, and this is best done during a time when it's quiescent, not inflamed. We can see that in the piriform sinus, some of the contrast material is collecting, and we can see that there is this tract that develops, or that is present rather, and that ends near the thyroid gland. Like I said, only 50% sensitivity. And in some occasions, if there is an active infection, if there's purulence or an abscess, you can get some of that fluid either via incision and drainage and collecting the fluid, or needle aspiration. And if you send it for salivary amylase, you will see that it shows up in these lesions, confirming that there is a connection with the pharynx. This is our last slide, so let's focus just for another 30 seconds. So how do we manage these? Well, there's evolving management to include endoscopic techniques over the past 10 to 15 years, I would say. So this is my preferred initial management technique. We see a picture here on the top right. Within the piriform sinus, there is a fistula opening. Well, you can cauterize these openings. In fact, a study out of Texas Children's showed that 21 out of 23 of their third to fourth branchial anomalies was managed endoscopically. That includes 2 who failed open management. We can see in this bottom picture what's called a Bugby cautery. It's a flexible yet a little bit firm cautery device that we can pass through the oral cavity into the piriform sinus, and we can cannulate that piriform sinus tract and turn the cautery on, cause a mucosal injury, cause it to scar up, and then therefore take away that connection between the pharynx and the neck. If you fail on one endoscopic attempt, you can retry an endoscopic attempt before considering an open attempt, which would include removal of the cyst, which sometimes means removal of that side of the thyroid gland if it's embedded within the thyroid gland, and you follow that tract superiorly and ligate it as it enters the cricothyroid membrane. Okay, folks, that was a quick run through of branchial cleft anomalies. I did list my email address here because I want you to reach out to me if I can be of help, whether you ask a question now or if you want to, reach out to me in the future. Please, does anybody have any questions?
Yeah, feel free to use the chat box or even unmute yourself.
All right, yeah, I'm seeing nothing in the chat box now, but there is our contact information, which is great. Okay, from a friend in the community, Dr. Flayes, is asking us, we see a large volume of patients and are challenged to refer appropriately. Red flags we should look for are examples of patients who you wish had seen sooner. So we actually have, Shelley, we have a new way for patients to get to us through MyChart. There are also on the MyChart application, there are some ways to triage patients. We have basically a system where we assign points to the presentation. So things that I would like referred sooner, for example, would be if there is signs of infection or inflammation. That would mean that the child's going to need some acute treatment. And of course, you guys are the first line and will likely put the child on antibiotics and sometimes order some imaging, but we're happy to fast track that, whether it is via a quick appointment within 1 to 2 days, or even a quick telemedicine appointment within a day or two, calm the situation down, perhaps order some imaging and some antibiotics, and then see them within a week after things have calmed down. But I would say the ones that we want fast-tracked are those that have skin redness, or fever, new onset discomfort, which would suggest there's an active infection. And of course, if there's any new onset airway symptom or swallowing symptom, difficulty swallowing, difficulty breathing, that we will fast-track. We will always get that in quickly for you. And I think that our new ways of triaging patients and the new MyChart functionality will be a lot faster than going through KidsDoc, which I know has been cumbersome in the past.
I just wanted to add, I agree with everything that Doug said, and just wanted to add that all of our, that we see patients at all of the satellites, as well as downtown at Lurie. So, not every surgeon goes to every single place, but all of us go to all of the Lurie satellites, or someone does, and it's appropriate for patients to be seen for a first initial visit there, or as Dr. Johnston said, via telehealth. So we want to make it as easy as possible, as quickly as possible for your patients to be seen. And of course, you can always reach out to us, and if you're having any trouble getting stuck, and we can make those things happen pretty rapidly.
Any other questions? All right, well, thank you for joining us this morning. Dr. Johnston and Monica, thank you so much.
Thank you all. Sorry we were a bit late. There's an accident getting into the hospital today, so I apologize.
Oh.
All right,
Well,
take care.
This is recorded for later.
Oh.